Hello, everyone. It is 2 p.m. on the dot where we are at here in North Carolina, and where Michael is in Tennessee is not 2 p.m. It is a different time, but it is time to start our broadcast. Good afternoon, everyone, and welcome to today's Health Solutions webinar hosted by Patagonia Health. Today's webinar topic is exploring rural health. My name is Dana Riddle, and I will be your moderator for today. You can go ahead and change the slide. Great. Can you do that one more time? Perfect. If you are not familiar with the GoToWebinar platform, no worries. Look for the communications box on the right side of your screen. That will be your hub to let you know how to ask questions or put something in the chat. That's your way of letting us know, since all attendees will be muted throughout the presentation. The arrow in the little red box at the top of this communications box allows you to shrink or expand the box as necessary. If you have any questions during the presentation, please enter them into the questions field in this box, and we will address them at the end of the presentation. Can you change slide? Perfect. Our presenter today is Michael Meit. Michael is the director of the Center for Rural Health Research at East Tennessee State University. Michael currently leads studies focused on the evaluation of rural health programs, health equity, and opioid misuse, among others. In 2019, Michael was named the National Rural Health Association's Outstanding Researcher. We are so excited to have him joining us to share his expertise on rural health. Now I'm going to turn the presentation over to you, Michael, but I will be back with everyone at the end to help address your questions. Thanks.
All right, thank you so much. So I'm really delighted to be speaking with all of you today. I'm actually in the northeast corner of Tennessee where it is 2 p.m. The rest of our state is Central Time Zone. So we're about 1/3 Eastern, 2/3 Central. What I want to talk to you about today, and you'll see the agenda here, I want to talk through briefly rural health inequities. I want to talk a lot more about the impacts of poverty, which underpin a lot of those inequities. Flip the switch a little bit to think about prosperity, which is the other side of the coin from poverty. And then I want to talk a little bit about some of our public health systems work as well. I understand that many of you are in health departments, so I do want to talk about what financing looks like in health departments. And then I want to end on a positive note talking about rural resilience, particularly strengths and assets, which is really, really important to us. Because so much of the challenge that we face in rural areas can kind of be negative and a little depressing. So we want to also make sure we talk about those good things in our communities, the things we're proud of. So I'm going to start again, just a couple of slides on rural health inequities. This is where I always begin, and sometimes I wonder whether this is the best place to begin because it's not necessarily an intuitive slide. But what you're looking at here are the trends in age-adjusted mortality for 1999 up to 2015. So this is a little bit outdated, but you would see that those lines kind of continue on the trajectory that you see here. The reason this is confusing is that this is rural in the green line and everyone in the gray line. So this isn't a rural-urban comparison. This is rural compared to everybody, including rural. The reason I show it that way, though, is that we have this narrative in the United States where we talk with pride about how each generation is healthier than the last, how life expectancy is growing, people are less likely to die generation after generation. And you can see in that gray line that by and large, that's a true story. But the reason I show this is that rural America has not shared in that success story. And in fact, the disparity, the delta between the two has grown over the years. And you'll see that 2015, the distance between those lines is much, much more significant than it was back in 1999. And again, if you extend that out to 2020, which is the most recent data we have, you'll see that it's gotten even more disparate. And why is this? So this is a slide from CDC looking at the 5 leading causes of death. What you have here, and I'll explain it a little bit because again, nothing in rural health is intuitive, I'm afraid, but we have 2 rural definitions that are shown here. 6 geographic definitions as a whole, 2 of these are rural, and those are called micropolitan and non-core, which again, doesn't make a lot of sense necessarily, but you can think of them as kind of small town rural communities as the micropolitan, and more remote rural communities as the non-core. What I want you to see here, though, is that for each of the 5 leading causes of death, that disparity, that inequity is so much greater in our rural communities as compared to our non-rural communities. And in fact, if we were to extend this chart out to the 10 leading causes of death, what you would find is similar inequities on 9 of the 10. The only exception is homicide, which tends to have more of an urban focus, but even then, that focus is only for men. In many states, the inequity is still there for rural women because of domestic violence and abuse. That's all I'm going to go into in particular on health disparities, because I want to shift gears a little bit and talk about what I think underpins most of these health disparities, which is poverty. So in public health, we talk about the social determinants of health. I prefer to refer to them as social drivers of health, and I'll tell you why in a little bit. But most of you are probably familiar with the social determinants: educational access, healthcare access, neighborhood and built environment, economic stability, and social and community context. All of these, without a doubt, are really important to health and well-being. But I would also argue that all of these are underpinned by poverty. If you live in poverty, you are less likely to have that educational access, less likely to have that economic stability, that healthcare access, etc. The reason I don't like calling these determinants is that the work we do in rural health, the work we do in public health, is to really help communities overcome challenges despite the headwaters. And when we use the word determinants, it makes it sound like these things are predetermined. There's nothing we can do. Why are we acting on these if it's predetermined? So certainly these drive healthcare outcomes, but I believe there's a lot we can do to still shift that dynamic. And I'm going to share a story with you at the end that I think really provides evidence of that. So drilling into this a little bit, this is really one of my favorite slides, and I think I show it in every presentation I do. But to me, this is what is happening in rural America that really shows why we are experiencing this kind of poverty. So this is the employment index. So this is job growth to and through the economic recession of 2008. What you see is that up until and through the economic recession, that orange and blue line are pretty much the same. They overlap, they cross a couple times, but the recovery since the economic recession has been an urban recovery. And urban areas have boomed. They're doing far better than they were than before the recession. Rural areas have stagnated and in fact have never fully recovered from the economic recession of 2008. That growing divide is why we see more poverty in rural areas, and it is in fact why rural people feel like they've been left behind and why they're often angry about that. And I think if you look at this slide, it's kind of hard to argue that they haven't been left behind. So I want you to think about that a little bit as I share the next slides. So what I'm showing you now is a comparison on different health measures between the 2% of the wealthiest counties in the United States compared to the 2% of the poorest. And there's an important caveat here. This is poor versus rich. This is not urban versus rural, but the vast majority of the poorest counties are rural and the vast majority of the wealthiest counties are urban. The correlation between those two is super strong. And what we see is 3 times greater premature death in our more rural counties, or I'm sorry, in our poorest counties. We see that people in our poorest counties are twice as likely to smoke. They're 50% more likely to be obese, half as likely to have college education, and children living in our poorest counties are 6 times more likely to be living in poverty. That should be an embarrassment for our nation and a call to action. And again, this disparity is what we see much more so in our rural communities than in our rich communities, our urban communities. And I'll show this to you in another way as well. So what I'm sharing with you now is what we call our prosperity index. And this was a product that we developed while I was at NORC. And I should mention that logo in the upper right corner is the logo for our Joint Research Center between ETSU and NORC. We have one of the federally funded rural health research centers, which is the ETSU NORC Rural Health Equity Research Center. So we developed this prosperity index, and it is a 16 measure index, which is shown on this 2x2 matrix. We thought about economic factors and social factors, and we also thought about both risk and resilience. The resilience part was really, really important because that's that positive piece, that assets piece. And if you look at what's included in here, all of them are equally weighted, but we have poverty rate, we have high school dropout rate, we have voter participation rate, which is a really, really important measure of community engagement. We have number of hospital beds per 10,000 population. That's actually an indicator of economic strength because that's often the largest employer in our communities. So this is what is included in the index. And when we map it, this is what you find. And so this is a tool we recently completed and developed for the Centers for Disease Control and Prevention. I have the website here. It is ruralhealthmap.norc.org. What I want you to know about this tool, I'm sharing the Prosperity Index. I'll show you a couple of other slides from this tool as well, but there's a ton of information in here. You can get county level COVID-19 information, vaccination information, hospitalization information. You can get the Prosperity Index data. You can also create maps for each of those 10 leading causes of death. So I told you at the front that rural communities fare worse on 9 of the 10 leading causes of death. You can actually map this for every county in the United States. So as you look at this map, I just want you to focus in for a second here. So as you do that, look at the dark brown and light brown counties. These are the counties that fare worse in terms of prosperity, so the poorest counties. And you'll notice probably areas of the country that you could name. You'll see Central Appalachia. You'll see the Delta region. You'll see the rural South. Often we call it the Black Belt because of the rich soil. You'll see the US-Mexico border region. And in the Plain States, what you're looking at there is by and large Indian reservations. That's where we have the deepest poverty in the United States. So I'm going to compare this to a few maps. I'm a very visual person. This is kind of helpful for me to think about this. So now you're comparing the Prosperity Index to a map of persistent poverty counties in the United States. So for those of you not familiar with the concept of persistent poverty, it's a really dramatic one in my mind. To be defined as a persistent poverty county in the United States, more than 20% of your population has to live below the federal poverty line since the 1980 census. So 1980 census, 1990 census, 2000 census, etc. These are counties that have faced 40 years of intergenerational poverty. You'll notice that the dark red counties are rural, the light red are metro. You'll see vast majority are rural. And if you compare those maps, you'll see the same regions of the country: Central Appalachia, the Black Belt, the Delta region, the US-Mexico border region, and Indian reservations. Now on the left is one of those maps we pulled down from that rural health mapping tool I shared with you. So this is a map of cardiovascular disease mortality in the United States. And again, compare the dark and light brown counties on the right to the darker blue counties on the left, where we have higher cardiovascular disease mortality. And you'll see that by and large, we are looking at the same counties. You can particularly see that when you go up to the Indian reservations. This is a map of respiratory disease. And I could go through any of the leading causes and it would look very, very similar. Let me show you this in another way though. So now the map on the left is where we have the greatest proportion of rural African Americans in the United States. And again, you see the Delta, you see the Black Belt. These are the counties with the greatest proportion of Hispanics in the United States, and you see those counties in the US-Mexico border region. And then this is a map of where we have Native American, the greatest Native American populations living in rural counties. These are typically Indian reservations. And you see those same counties up in the Plain States and some in the Southwest. This should not be a surprise to us, but it should be a call to action. So the other thing I want you to know about this tool, and to me it's the most important feature of this tool, is that if you click on a county, you can pull this data for any county in the United States. You can compare the data for your county to the data for your state to the data for the entire country. I often pick on Virginia because Virginia has some of the greatest health or wealth gaps, the gap between the richest and poorest, greatest wealth gap of any state in the United States. The poorest counties in Virginia tend to be in the tail of Virginia, just north of where I live in the Appalachian region. The wealthiest counties in Virginia tend to be those counties that are border counties around Washington, D.C. This is a map, this is the chart of the Prosperity Index data for Dickinson County, which is the poorest county in Virginia. And just look at some of these measures. Poverty rate is 2.5 times what it is for the state. Voter participation rate, 53%. Educational attainment, 10% of people have their bachelor's degrees. Compare this to the richest county in Virginia, Loudoun County. Voter participation rate is 82%. The poverty rate is 1/3 of what it is in the what it is in Virginia as a whole. And there's the educational attainment, 61% instead of 10%. So again, that's the difference between rich and poor in one single state. You can do this exercise, and I often do these presentations around the country. You can do this exercise for any state in the nation, and you'll see those gaps, and it's really, really dramatic. So I'm going to shift gears a little bit, and I'm really happy to take a lot of questions at the end. I think we'll have plenty of time because I talk pretty fast. But I want to shift gears a little bit and talk about this in the context of rural public health. Again, this is where I like to start because when we talk about rural health challenges in the United States, this is usually what people start to gravitate towards, which is the hospital crisis, the hospital closure crisis in rural America. It is absolutely a dramatic crisis in our rural communities. We have rural hospitals closing, communities losing access. That makes it a lot harder for those communities to recover economically. Big, big challenge. What we don't often talk about is that a lot of this is also happening in our public health system across the United States. The data regarding our public health system is much more limited, so we usually have to find this in the newspaper. We don't just have good systematic data to track this the way that we can track hospital closures, so it's often underreported. And then this has been further complicated during COVID-19 because many of our public health workers and public health officials have been under attack, mostly verbally, but sometimes even physically, and many of them have left their jobs or been fired because of the difficulties in just doing public health work in this day and age. So in the context of that, I want to share this data with you. So this is data looking at financial data, revenue data from health departments using the NACCHO profile. NACCHO is the National Association of County and City Health Officials. The top two bars are rural, small rural, and large rural. Again, we use different terms different times. Large rural is kind of that micropolitan. Small rural is that non-core. But those are the two rural definitions compared to the rest of the health departments, which are urban. And you see that the bars differ greatly. So urban health departments have a lot more local resource. Rural health departments are proportionally more reliant on state and local flow through, which is the blue and the yellow. And rural health departments are much, much more reliant on clinical revenue dollars, which is the dark blue. So what does this mean in the context of what's happening in our public health system? Well, not as much during COVID, but prior to COVID, we were seeing a lot of state and federal budget cuts. And I guarantee you that post-COVID, these things go in ebbs and flows. We will see state and federal budget cuts again. This is a lot harder for rural health departments where you're more reliant on those state and federal dollars and have less local revenue to fall back on. When we look at this in the context of that reliance on categorical funding, that limits health department flexibility. And as I mentioned, our rural health departments are proportionally more reliant on state and federal flow-through dollars, so money that comes through the state from the federal government. Those dollars have requirements tied to them, so the local health departments do not have as much flexibility. That's more true for rural health departments than urban. And then what's been interesting has been tracking what has been happening as a result of health reform. Health reform created opportunities for both urban and rural health departments, but probably different types of opportunities. So if you are an urban health department and you have a whole lot of local revenue, you may decide that you no longer need to do those clinical services. You can shift those to others in your community because you have ample supply of other providers. You can refocus your efforts using local dollars. On the other hand, if you're a rural health department, you now have potential revenue to pay for those clinical services that were uncompensated previously. You can now bill for those services. And in fact, many rural health departments have expanded clinical services as a way to cost shift, if you will, to help supplement other services. So the implication of this is that our rural and urban health departments are headed in different directions. And we need to be thinking as a field in public health about what are the implications of health departments moving in different directions in terms of the types of services they provide. So the last area I want to get into is my favorite area, which is strengths and assets in our rural communities. And this is where I'm going to share a story with you. But when we talk about our rural communities, it's so easy to get caught up on all of the challenges, all of the negativity. But we also need to recognize that we have very close-knit communities. There's a lot of pride, a lot of independence and self-reliance. The work ethic is strong. You know, the narrative we often hear is older, poorer, sicker, or people are addicted, or people are unemployed. Those challenges exist in our communities, maybe more so than urban communities, but they don't define our communities, and they're still a small proportion of what happens in our rural communities, and we need to be telling the story about what is good and what is strong. That's our path forward. Leaning into the fact that we have people who are hardworking, who want to do good work, is a rural story that we need to talk about. Social cohesion in our rural communities, we have this culture of collaboration, a lot of collective efficacy. People come together to solve problems. That's a strength. And then the level of innovation is just off the charts. It happens because in rural communities, nobody is throwing money at the problems. We can't go to foundations, we can't go to federal agencies and say, give us money, we have problems. We have to look inward to ourselves and say, how do we solve our problems on our own? As a result, we often do it on the cheap in very creative ways, and we should be guiding the rest of the nation in how to solve problems because we know how to do it. Those are some of our assets. So I want to just take you back, and again, this is the story I want to share with you. So I want to set it up by going back to this map of persistent poverty. Again, this is defined as greater than 20% of your residents living below the federal poverty line since the 1980 census. And I just want to zoom into Eastern Kentucky, Central Appalachia. So this is pretty shocking. So almost all of the counties in Eastern Kentucky are these persistent poverty counties. Now look at this map. Let me tell you what you're looking at here. So this is a map comparing 2 5-year points in time. So comparing data from 2008 to 2012 to the next 5 years, 2013 to 2017. And the darker orange are the areas that have had the steepest increase in overdose mortality. So you're looking at maps of drug overdose mortality. The darkest green are the counties that have had the steepest decline in overdose mortality. And lo and behold, the areas with the steepest decline in overdose mortality are the poorest areas in all of Appalachia. Again, if social determinants determined our health outcomes, this wouldn't be possible. Let me show this to you in another way. So these are 8 counties in Eastern Kentucky. And when we look at every county in the United States, 3,124 counties in the United States, we look at every one of those counties and we rank order them. Of the 10 counties in the entire United States with the steepest decline in overdose mortality, these 8 are in that 10. So 8 of the 10 counties with the steepest decline are in Eastern Kentucky, and 14 of the top 20 are in Eastern Kentucky. That's amazing. Now, I do want to point out, we don't want to have rose-colored glasses. All of these rates are still higher than the national average. There's still work to be done, but you can still do hard work while celebrating your success, and this is a success that should be celebrated. So we were able to get funding from the Centers for Disease Control and Prevention to go to these counties and talk to stakeholders. We talked to over 40 stakeholders to try to understand what was happening. What did they do to bend the curve in this direction? And this is what we found. There was a strong focus on increasing access to treatment. That happened in Kentucky before they expanded Medicaid. They had a treatment voucher program. They really were focused in on helping people get access to treatment as quickly as they could. But boy, expanding Medicaid accelerated that greatly. They included a really robust treatment benefit in their Medicaid expansion. And in doing so, you can now get treatment on demand in Eastern Kentucky. Just as an anecdote, I talked with a stakeholder here in Tennessee who was saying that many of our substance use treatment centers have 4- and 5-week waiting lists. And think about how tragic that is. Somebody decides they're ready to go into treatment and you tell them they have to wait 4 or 5 weeks. I mentioned this to a colleague in Kentucky who runs one of these treatment centers, and he said they get upset if they make somebody wait more than 2 hours. That's the difference that increased access and treatment on demand can make. Big focus on building a recovery community. So that includes recovery housing, second chance employment, other factors to support people in their recovery. They engaged the criminal justice system. There are judges in Eastern Kentucky who are more likely to refer people to treatment than incarceration. There's a program, actually it's called the Angel Initiative, where anyone can walk into a state police barracks and they will put them in a squad car and drive them to treatment, no questions asked. That's amazing stuff. Harm reduction programs, needle exchange. This is controversial, particularly in rural communities, but would you believe that the state of Kentucky has more needle exchange programs than any other state in the United States, and the vast majority of them are in rural communities? That's because they saw a need, despite stigma, despite opposition, people came together and said, we need to advocate for this because this is important to save lives in our community. A lot of focus on reducing stigma, increasing partnerships, community coalitions, a lot of primary prevention, really an all-hands approach where everyone at every level in the communities in a bipartisan way, which I think is important, came together to solve this problem. I like talking about the bipartisan way because we don't see a lot of that in this day and age, but a lot of these initiatives were started by a Republican governor, handed off to the next governor who was a Democrat who expanded Medicaid, handed off to the next governor who continued down this path of increasing access to treatment, and the current governor is another Democrat. Did not matter who was in charge. Everyone was singularly focused on this challenge, and I think that's why we see some of this difference. So this is really, I think, the last slide I want to share with you, but when we did this study, we did this 4 or 5 years ago, and we didn't know what to call what was happening in Eastern Kentucky. But today we would call it a recovery ecosystem. So the idea of a recovery ecosystem is, and actually I think I have a couple slides after this showing another tool actually, but the idea behind a recovery ecosystem is creating support systems for people to maintain their active recovery. Getting them through treatment is great, but you need to think about what happens after treatment. How do we help them sustain that recovery? I like this slide because on the left you see who should be involved. Criminal justice, treatment providers, community. In the middle, you see what should we be doing? Case management, peer support, providing stable housing. And then on the right, what are the outcomes we want to see? We want people to have employment, transportation, housing, and social support. If we can ensure those things, people are going to be more likely to be successful in their recovery. If we don't provide those things, if people can't find gainful employment because they have a record, if they can't find housing because they have a record, they're going to fall back into substance use because that's what they know. So the reason I like to show this, again, going back to what I showed you here in Eastern Kentucky, well, what did they do? Again, they built a recovery ecosystem. Again, we didn't know what to call it when we did the study, but today that's what we would say. In Eastern Kentucky, they built a recovery ecosystem. So last couple of slides, I shared with you our ruralhealthmap.norc.org slide. Now I want to share with you our rural recovery ecosystem mapping tool. It is rei.norc.org. So similar in concept to the Prosperity Index, we came up with a set of measures. In this case, we have 14 measures, which you see here. It includes things related to substance use treatment facilities per capita, the presence of drug-free coalitions, vehicle availability. You see all of these different resources here. And when we map those, It looks similar to the other map, but you'll notice some important differences when you dig into this. What you'll notice is Eastern Kentucky, which has very high poverty, actually has a very strong recovery ecosystem. Everything I just shared with you from that study. The areas that have the strongest ecosystems, the strongest recovery ecosystems in the United States are the areas that have had the greatest challenge with substance misuse in the United States. That may sound counterintuitive, but it actually makes sense. Again, this is the rural strength I like to talk about. When we have a problem in rural America, people in our communities come together to figure out how to solve the problem. So in rural America, in Appalachia, we had a very big challenge with substance misuse. We built systems to ensure recovery support systems. We built a recovery ecosystem to address it. There are areas where we need to do better, but this is the other beauty of the tool. Like our other tools, you can click on any county in the country and get your own data. So this is looking at Pike County, Kentucky. You can pull up the data and see how your county compares on any of those indicators to your state and then to the nation. And it helps you identify the areas where you can strengthen your recovery ecosystems and provide better support. And I think with that, I am happy to take any questions people may have.
Great, thank you so much for sharing your expertise. Yeah, I'm definitely going to go through the questions we have. If you have a question that you haven't typed, go ahead and type it in the questions chat box. The first question we had is about the slides, if the slides will be made available. I'll leave that up to Michael, but I will say as well that you will be sent a recording of this webinar.
Yeah, and I'm happy to share slides with anyone who would like them.
Okay, great. A second question would be, you're talking about aligning our goals for treatment, and I think that's something that is brought up a lot with between rural and urban communities. Do you have any tips on how to increase that communication or better that communication between health departments so that we're all kind of on the same page, kind of like Eastern Kentucky was?
Yeah, I think this is what I love about local public health is people get out in the community, they're part of the community, they know the community. Our local public health workers are from the community, and that helps. And actually, I think local public health is probably more trusted than state public health, and state public health is probably more trusted than the federal public health agencies. The closer we get to our community, the better those relationships and the more trust we have. I think that's really important. I do think some of that has been damaged during COVID-19. I think a lot of what happened was that the pandemic got politicized, which I think is really unfortunate, but it is the reality. But even then, I think by and large, there's still more trust than not. And I think we just need to leverage that trust.
For sure. Another question that we got was, can you talk about or share some successes in regards to public health programs that have made poverty reduction their primary goal?
That's a great question. I don't know of a lot of direct public health initiatives that have focused on poverty. I think as a field, we need to be more engaged with our economic development partners and talking to them and thinking about how we work with them, because I do think that if I were to wave a magic wand, the one public health intervention I would try to do is make sure everyone had a living wage. If everyone had a living wage, health would improve dramatically by itself. So I do think this economic piece is really central to ensuring health and well-being. And often we are working in our own little silos and we don't have those discussions with our partners. That said, I do think things that we do related to building trails, community parks, different types of initiatives like that are good for health and the economy. They make places that people want to live. So I do think we have a lot of alignment between our ultimate objectives, and we just need to be thinking about that more. One thing I will share with you, I'll share a little anecdote. I was asked to give a presentation on health and all policies at one point to a very diverse audience of people from different sectors. And, I gave kind of the standard public health and all policies presentation. And at the end of it, somebody said, well, I work in education. Why is it health and all policies? Education is just important. We could call it education and all policies. Somebody else said, well, I work in economic development. Why are we not the center? Why do you health people think you should be the center and everything should relate back to health? And I think we should question that. I'm not sure that necessarily is the messaging that moves us forward. I think we need to partner as equal partners and not necessarily see ourselves as the be all end all, because all of these things are important to our goals and their goals.
Great. Somebody's asking about the tool that you had mentioned earlier. How do you enter your area to look up what's going on like in your community? She was saying that you mentioned it at the end.
So the Rural Health Map tool, it's ruralhealthmap.norc.org. And we also have the Recovery Ecosystem Index tool, rei.norc.org. We also have an overdose mapping tool, which is the opioid misuse tool.norc.org. All of these have the same scroll functionality so that if you click on a county, you can zoom in, click on any county in the country, and then it will open a box. And when you click more details, it will pull your county data. Some of those tools have different functionalities where you can plot where treatment centers are, for example. There's also on the upper left side, there's also a place where you can search by county. So you can start to type in the name of your county and it'll pull it up as well.
Thanks. I think we have one more question. That would be, you kind of mentioned, especially when talking about the opioid issues going on, that there seems to be more of a connection that needs to be made between public health and behavioral health. Can you talk a little bit about that and how that's kind of changed over the years?
Yeah, absolutely. So, I will say I am living here in Central Appalachia. We are at the center of the opioid crisis, along with our colleagues in the Northeast, along with our colleagues in the Southwest. Our three regions are really the epicenter of the opioid crisis. So that is an area where, when we're thinking about public health challenges, it's front and center for all of us. That corresponds directly to behavioral health, to mental health, to isolation, to substance use treatment, all of these things. And I do think in our regions, because of the challenges we faced, we have had to build better integration between behavioral health and public health. Probably happens better in some places than others. There's always room for improvement. But I do think that we've kind of been forced to build those relationships that probably always should have been there. And I do encourage all of you who are in other regions of the country who have not faced the same level of crisis, it probably is coming to you at some point, and having those systems and structures and relationships in place will behoove you when the crisis comes to you. And I think that's happening. And in fact, when we look at the latest data available, which is 2020 data, 2021 data should be coming out any time now, the magnitude of the opioid crisis has just increased dramatically during the COVID pandemic. And it's hard to separate things out. And as fentanyl has become more and more prevalent in a lot of the illicit substances that we see.
For sure. Someone just asked, this is again with programs, are you aware of any successful programs or efforts aimed at supporting and retaining local healthcare workforce in rural settings?
So on the healthcare delivery side, I think there's a lot. It doesn't mean that every community is accessing all of the resources as well as we would like, but there are J-1 visa programs to bring in foreign medical graduates. There is the National Health Service Corps for loan repayment programs. There are state programs, there are federal programs. So I think there's a lot of that on the healthcare delivery side for a lot of different health professions. There is talk about doing it more on the public health side, but I don't think we've done as much as we should, certainly, in terms of making sure that we have a really robust public health workforce in our rural communities.
And then I have another question. You mentioned social determinants of health and how local business partners can help with rural poverty. Are there any other ways that Public Health 3.0 initiatives, such as technology, are making a difference in those areas?
Yeah, yeah, absolutely. I mean, technology has helped. We've seen a migration back into a lot of rural communities because of telework. So certainly technology helps. I think there's question whether that will have staying power post-COVID, whether employers will be as friendly towards remote workers, things like that. But certainly as technology has gotten better, that has brought opportunity to our rural communities. But when we have lower educational attainment, fewer healthcare facilities, fewer economic engines, businesses in our rural communities, that investment is hard to bring in. And these things get harder. So I talked about hospital closures. When you lose your hospital, you just made your job 10 times harder on recruiting a business to your community. So these things are really important to think of kind of in more of a macro way. How does one of these things influence another?
Awesome. I think those are all of the questions that we have. Could you turn to the next slide?
Yep.
Perfect. I just want to say a huge thank you to Michael Meit. Thanks everyone for attending and again for the expertise. If you would like to get in touch with our presenter, if you had any questions that weren't answered, please email him at meitmb, that is MEITMB, @mail.etsu.edu. And if you would like to learn about Patagonia Health and our integrated EHR, practice management and billing solution designed for public health departments and with integration to behavioral health organizations, please visit our website at patagoniahealth.com, or if you'd like in demo, email mark@patagoniahealth.com. Thank you, everyone. Have a great day.